got married, I was a pretty sight, but now, luckily, I'm still already married, and so it doesn't matter, hey?
I think we can start.
Good. Well, good afternoon, ladies and gentlemen, and a warm welcome from a very hot Cape Town. In fact, it's 37 degrees Celsius outside and made hotter by a huge fire on the mountain. It gives us great pleasure on behalf of Sanofi, who's our sponsor, to invite Dr. Amy Wise, a consultant obstetrician and gynecology expert from the Rahima Musa Mother and Child Hospital, University of Wits in Johannesburg. And she's going to be speaking on vaccination in pregnancy in 2025, Tdap and influenza. My name is Peter de Jong, and my co-moderator is Professor Steve Jeffrey. As you all know, he is arguably one of the 10 best urogynecologists in Cape Town. And our technician this afternoon is Chris. And Chris, thank you very much indeed for being with us. It gives us great pleasure to have Dr. Amy Wise, who's on the SASOG committee as well. And we hope to have as many possible people in Cape Town as can be practical in October 2025. The beginning of this 2025 October, we have the FIGO meeting over here. And of course, vaccination in pregnancy is a huge topic at the FIGO meeting. So without any further waste of time, click on the SASOG or click on the FIGO icon on the website, and you'll get all the details of the programming, the workshops for Cape Town FIGO 2025. So Amy, I have your first slide up, and thank you very much indeed for agreeing to be with us this afternoon. You have spoken on this platform before, and you've gone on so well that by popular demand, people demand that you actually come back. So vaccination in pregnancy in 2025, Tdap and influenza, Dr. Amy Wise. Hello, Amy.
Dr. de Jong, I think I've lost you. Good afternoon, and thank you. I think they're going to just do the poll first, if I'm not mistaken.
Now we're going to start with a poll, and then we're going to end with a poll. Did you hear my introduction of yourself, Dr. Amy Wise?
I did most of it. Thank you so much.
Okay, right. So, ladies and gentlemen, if you have the poll in front of you, I'm going to ask you to complete the belief ladder questions for the audience, and we're going to redo it again at the end. This is a new term I've heard, Amy. Have you heard of a belief ladder question? That's something I'm familiar with in church, but not usually on the webinar. Is this a new term for you or just for me?
Yeah, I think from Sanofi's side, they've put this together really just to gauge, and make sure that the learning is useful and going to be translated into practice.
All right. So people are voting as we speak. Is that sufficient time, Chris, or do you want more time for the belief ladder?
Well, about 26% of participants have answered, so let's give it a few more seconds.
Okay. Steve, are you familiar with the term belief ladder?
No, Pete, I've never heard of it, so I'm interested to see how it works. Is it basically a feeling of gauging everyone's perceptions or impressions of things? Is that how it works?
Well, before and after. So we have these questions that the delegates can look at before, and then we have the same belief ladder at the end, and we see if Amy has swayed our perceptions by her presentation. Last time she did, but I'm just going to look at this is slightly more scientific, because we can see then the direction and the degree of change that has been affected by Amy's presentation?
So, Dr. De Jong, maybe I can just jump in there. It's Lawrence from Sanofi's side. I think you captured it exactly correctly. We're trying to get an impression of where our HCPs or obstetricians are at in terms of specific topics, right? So today we're going to be talking about vaccination in pregnancy specifically. So to get an idea of what people think of local disease burden, vaccination in general, and then also vaccination in pregnancy specifically, and then kind of asking the same questions at the end will allow us to see really the impact, right? And that's where, from our side, we're trying to shift our efforts as well, that we execute these educational activities or sponsorships in a way where we can see that it makes an impact. And if we feel it's not making an impact, that we address that, right? So that we see.
Okay. Lawrence, thanks very much indeed. I thank you on behalf of the Pelvic Floor Foundation for Sanofi for your belief ladder. Is this term something that is used commonly in scientific polls, or is it usually confined to the catechism in church?
It's actually more scientific than the first impression may be. So there's what we call a KAB ladder, actually. So the K would stand for knowledge, and then the A for attitude. So kind of how somebody's perception of something is and what their approach that is. And then the B would be the belief ladder part.
Okay. Thank you.
Or behavior part as well. So you can really assess somebody's current knowledge, what their attitude towards something is, and then what their behavioral practice in their practice is, and then hopefully the shift over time or pre or post intervention.
Now we look at number E. Lawrence, why haven't people answered question E on your belief ladder? Vaccination in pregnancy is not a recommended best practice. Do they have to touch that then? I know we can't. We are moderators. We don't have any ability here. But why does nobody touch E?
So we don't want to steal Amy's show, but the way these questions are designed is to give you a spectrum of options to then pick, right? So from one extreme to another, but they're meant to not be in any particular order necessarily. And the user can pick whichever option they feel most aligned to. There's no right or wrong answer. But it is on a spectrum, and then as we mentioned, then we're hoping to see more answers towards the end that are aligned to what recommended best practice is for vaccination and pregnancy.
Okay, thank you. Shall we then proceed with the presentation?
I think so. When Dr. Amy is ready, then yeah, we can proceed.
Hi, I'm ready. I just think they're going to ask that when the poll comes down, then I'll start. Thanks, sir.
Thank you. Who takes the poll down, Christopher or Lawrence? Chris?
That would be me. The poll should be down. Are you still seeing it?
I'm still seeing it. And it's gone now from my side. Right. Good evening, everyone. And thank you very, very much to Sanofi and to the Pelvic Floor Society for inviting me. Again, the poll is back.
Shall we just press close? There we go.
Yeah. So, yeah, thank you very much for inviting me this evening. And yeah, I'm talking from Johannesburg, so it's a lot as Cape Town, but my daughter who recently last year, I'm back again this year. And when I was having a look at what is new, because sometimes one feels, is anything new in medicine? But really in the field of vaccination, things have moved along quite quickly. And there was actually quite a lot of new information that has come through. I'm just trying to see that my slide now moves, because it certainly moved earlier. Right, there we go. All right, so thank you very much, as I said, to Sanofi. This presentation is intended to facilitate continuing medical education, and the views really are my own and do not necessarily reflect the views of Sanofi, and they do not recommend the use of any of their products in a manner inconsistent with the local package insert. And to please, before using any products mentioned here, and please refer to the full local prescribing information. So as a starting umbrella for everything, we're looking at how to reduce mortality, and with the new guidelines that have been presented for maternity care, they've got a whole package of options which we can use to try and reduce mortality and morbidity in our patients. And there you can see up on the top left, perinatal deaths, and under that is maternal vaccinations, tetanus, toxoid, hepatitis B, and the flu vaccine. So this fits very much so within that bundle of care that we're trying to give to our mums. So where did we come from? So back in 2017, with the third edition of the maternity care guidelines, we had just tetanus or the TD option in the guideline. And so in those sort of 7 to 8 years, we've moved on quite a lot. And we now find ourselves in the 2024 National Integrated Maternity Care Guidelines. And I hope you all have your copy downloaded off Knowledge Hub. And what they've got now is a whole string of vaccines. So recommended is Tdap, influenza, COVID-19, according to national guidelines, but to my knowledge, no one at the moment, and I'm not even sure if there's any stock in.
Amy,
Not
we
included
can't hear.
yet in the 2024 guideline is RSV. So that is just recently released, but is not yet in the was not included in the maternity care guidelines. It was that new. So vaccine preventable morbidity and mortality, and while we are focusing a lot on our babies and trying to save them, I found the article that I took this information from very important and quite interesting, that 42,000 adults versus 300 children die each year from vaccine preventable illnesses in the US. And more than 50% of cases of significant vaccine preventable illnesses reported to the CDC in 2004 were in people over the age of 15 years. So we then see that there is another large gap in our population of where we are not doing our boosters regularly every 10 years as is recommended. So many of the vulnerable adults seen in practices that provide healthcare are to women, certainly within your gynae practices, and I imagine certainly those working with pelvic floor are dealing with an older, more vulnerable population and should be having a look at their vaccine status, especially if you're going to be planning surgery. So vaccination services, though, have not historically been part of obs and gynae care. But if we look back to the children again, our period of vulnerability for infants with infectious diseases is that time just after birth. And I'm sure many of you are familiar with this slide, but it is a slide that needs to be reiterated, that we've got this gap from just after delivery up through to potentially around about 3 to 4 months and on to 6 months, where we're waiting for the babies to get their vaccinations as scheduled by the EPI, but their own innate immunity has not really caught up yet. My two arrows on the left are highlighting the in this article, in this slide, it's put as the Dtap as opposed to Tdap, and the influenza virus. So those vaccines, which we are particularly looking at within vaccination and pregnancy. So we've got both active and passive immunization happening. So we vaccinate mum, who produces IgA, IgM, IgG, and then the passive immunization which occurs, which is the transplacental antibody transfer to the fetus of IgG, and then via the breast milk, both IgA, or all three, IgA, IgM, and IgG across to baby. So the importance of breastfeeding cannot be overemphasized enough. So that protection of the newborn then is both indirect and direct. So direct is that placental transfer, as I showed in the last slide, and that for the mom herself who gets direct vaccination so that she too is protected. The indirect benefit of vaccination and pregnancy is both through the herd immunity and that we then reduce disease transmission in the greater population. We try and improve this with school entry boosters, adolescent boosters, and adult boosters. Every so often they're intermittent campaigns. There's also the idea of cocooning strategies, and that was sort of where things started initially, where it was vaccination was offered to the whole family. This was before mom was getting it, to try and make sure everyone else didn't pick up the bug, to protect the baby. But that requires quite a big investment of time and money within a community, especially in large programs, to try and bring in whole families to get vaccinated as opposed to just vaccinating the mum. So when is the optimal timing for maternal immunization? This there's a lot of work done on this. So we know the half-life of maternally derived antibodies is short, and we want that seroprotection, though, to be extended as long as possible after birth, because we know there's that delay and lag until babies start receiving the immunization, starting at around 6 weeks. There's a prolonged maternal-fetal transfer, which cumulatively results in a higher amount of transferred IgG compared to a shorter exposure at the time of peak transfer efficacy. And we know that it also undergoes active transfer across the placenta. So if we then vaccinate a baby born at term, if they were vaccinated before 31 weeks, then they're going to have the highest levels. Both term and preterm infants, if they were vaccinated if the mother had been vaccinated more than 7.5 weeks between the delivery and the vaccination, they're going to have the highest blood-cord antibody levels. And so vaccinating earlier provides equally high antibody levels. So although you can vaccinate later in pregnancy, later into the third trimester, that's really not ideal. We really want that vaccination in earlier. So we're looking at vaccinating in the second and early third trimester, which is in line with the package insert from for the Tdap. And although the guidelines you'll see will have said, and I'll show you just now, 26 or 27 weeks and later for Tdap, it is perfectly okay within from the second trimester. And then we'll provide both equal benefits to both the term and preterm infants. There's about a quarter of the antibody left circulating in the baby. For all three components of the Tdap, we see that it's not affected by the gestational age at the time of maternal immunization, and this is referring to the decay, not the level of antibody that's going through. So how quickly does something decay? It's not affected by the gestational age at the time, the birth weight, maternal age, maternal vaccination status, and there they're referring to patients who potentially had the illness, so they've got natural antibodies to, say, pertussis. That pertussis, naturally acquired antibody, decays at the same rate as the antibody which was achieved by vaccination. And then the vaccine characteristics, and this then again refers to the different makes of vaccine from different companies. So it wasn't, that also did not affect the rate at which it decayed. So my table often as things update. So influenza. The influenza vaccine is really there to protect that pregnant mom, and we'd like her to get it early in the season. I looked to see when the flu vaccine was going to be available, but I actually didn't find an exact date, but I suspect it should be soon, and perhaps just now the rep from Sanofi can let us know. The tetanus and pertussis. So when I went into that new maternity care guideline that's been produced, there is both the bank chart, which gives what should be happening at each visit. So on that one, it says at 26 weeks is when you can start offering, or when you can offer the vaccine. But later on in the actual text, it says 27 weeks. So really 26, 27 is fine. But the point is that you want the vaccine given. So if we can give it even earlier in the second trimester, that's fine, so long as the patient gets it. And what's also important is that it's not that once we reach 36 weeks that we are done. If the patient only books at 36 weeks, or for some reason has missed the vaccination, I don't know, stock out or whatever might have occurred, please give the vaccine when she arrives, or even postpartum if the patient for some reason missed it during her pregnancy, or perhaps she declined it for whatever reason, please postpartum give it. There is still going to be that benefit. Hopefully the mum's going to breastfeed long term, and there will still be benefit if she receives it. The Tdap then is going to be repeated in every pregnancy. And this then is the departure from the previous guidance on tetanus, where we used to give the repeated tetanus injections, one and then 1 month later and then 6 months later. So we don't have those repeated tetanus injections now. It's just a single Tdap. For RSV itself, it's 32 to 36 weeks from the guidance from the CDC, and there isn't really the data yet to say for future pregnancy. So at the moment, the guidance is just in the index pregnancy, and we haven't yet got the data should you be repeating it in subsequent. that data will come at some point.
Amy, can I just ask there's some questions here to prevent them heaping up. Two questions. First from Moira Stein. She'd love to know your opinion on the RSV vaccination. Amy, are you hearing us?
Yes.
Yeah, she'd love to know your opinion on RSV vaccine, the vaccine that's been introduced into antenatal vaccine programs overseas. I'm in the UK as of 2025. What is your opinion then, RSV vaccination?
The burden of disease with RSV is massive within the small infants. So definitely, as soon as we're able to secure it as a more routine event, I think we will be using it. At the moment, it's not available widely. I'm not actually sure if they've got it yet. I know we've got it in some of our studies that they're still doing on this side. But I think once it's available, it will be a very useful vaccine to give, and I think definitely we'll be promoting it.
Excellent.
So-
The answer is yes.
Repeat
And
from my side.
the,
So Pete, from
I
my
think
side, I do know
Lawrence-
that, yeah.
No? Who?
So Pete, from my side, I think you can get the RSV, but it requires quite an intense application by the pediatrician. So they are getting it in private for some kids.
okay.
Yes, I think they are able to get it, but I think it's quite an extensive application.
Yeah, so I think it'll take a little bit of time for us to have it widely available. But certainly I know the pediatricians, Prof. Dangor, I know he's presented quite a lot on it, and he's really excited about the advent of the RSV vaccine. So yeah, so just back to these three. So the pertussis, the diphtheria, and the neonatal tetanus. So these are showing the cases as reported to the World Health Organization. So 268 cases of pertussis there between 2000 and 2023, 17 of diphtheria and 2 of neonatal tetanus. So this obviously depends on different data sources, but it certainly shows pertussis is in the lead. But there certainly from where I'm working, the notifications for pertussis are regular. Every couple of days, I get another notification to say, just at my hospital alone, that we have had another case of pertussis. So this is very hot off the press, actually, kindly supplied by a colleague from Sanofi. And this is looking at how much Tdap was supplied to the National Department of Health across 2024. So the rollout began at the beginning of 2024, and the number of vials then supplied was with a 1.8 million. And you can see starting in January, the blue bars are for the total for South Africa, and Gauteng I put next to, sorry, left off the Western Cape, apologies. But yeah, so with Gauteng off to a little bit of a slow start there in February, but then we sort of gained some momentum, and certainly by September we were ordering and giving out a lot. I did ask, was this ordering and the supply of these vials really equating to given? And it sounds from the way the data has been presented that certainly we are keeping up. Whatever we're ordering, we are giving. And since we've now stopped giving the tetanus in our antenatal clinics, that Tdap is being used. And so that's a massive number of vials that have been used in the last year. So I think it's a good reflection. So
Amy?
Yes.
Sorry, Kudichu Masoro says the concerns about RSV vaccines and GPS in the USA are real. Are we safe to administer it? Yes or no?
Yes, for the RSV. So one of the concerns, if they're talking about the preterm, I think the preterm birth was one of the concerns. Did it increase preterm birth? I think part of the problem was the RSV vaccine was trialed during COVID, at which point there was quite a lot of preterm birth, and so there were a lot of confounding factors.
Okay.
So there have been some ongoing studies, which is specifically to answer some of those questions, and that's why they've put, sort of out of abundance of caution, said that we're giving it at the moment from sort of that you're well into the 3rd trimester, but I suspect that you're going to see that newer data come.
Okay. And a final question from Leonel. Why the indemnity shield for vaccine companies so full immunity against prosecution? Are you aware of any of that or not?
Pardon?
Are you aware of that? The indemnity shield for vaccine companies?
No, maybe Lawrence can speak to the indemnity shield.
Okay. Lawrence?
I'm actually not sure what Leon is referring to. I don't know if it's maybe the disclaimer slide that we showed at the start. So that is standard practice to just give the speaker the opportunity to share their professional opinions, so that you as an attendee know that the views that they're sharing are their own.
Okay, thank you very much. Please proceed, Amy.
Thanks. So the maternal immunization, women living with HIV. So this is obviously an important thing to consider in our country, and the immune response from patients who have got their immune system affected. So we know that there's a trend for higher incidence of hospitalization for influenza and lower respiratory tract infections amongst infants who have been exposed but uninfected, compared with those who are uninfected and not exposed. So basically the babies, even though they're not infected with HIV, they are more likely to land up, if they've been exposed during pregnancy, being admitted with influenza. So pregnant women with HIV, they have a lower seroconversion rate and a lower persistence of influenza antibody that are specific, and a double dose is associated with a slightly greater immunogenicity compared with a single dose, although this is not practiced per se, but it is something to keep in mind. It's not in any of the guidelines that I'm aware of. So there's limited data on the vaccine efficacy within patients with HIV and their infants. We know that there is a similar efficacy against influenza infection when you compare the two different cohorts of infants, and that there was no difference observed specifically for adverse events between HIV positive and negative pregnant women. Again, there's always a concern about, if you give someone who's immunocompromised a vaccine, is there potentially going to be an effect? But overall, patients who are immunocompromised do.
Sorry, Amy, you cut out there. Overall, patients that are HIV positive do what?
Say that there's less than 1 per 1,000 live births per district per year. So that doesn't mean that strictly that it's entirely gone, because we have had 2 cases, as I've noted there, in the first 4 months of 2020 in Mpumalanga, and one of the infants demised, and it's usually related to poor cord hygiene. And certainly where we still see a fair bit of tetanus is within our
emergency.
sorry, just someone.
Pete, can you mute yourself, Pete? Thanks.
So, yeah, so certainly within our adult population, we do hear of cases quite regularly within our ICUs and things where unfortunately people have succumbed to tetanus. So again, as I said, there's that sort of gap in adult vaccination, so we should be doing it every 10 years. I know the one case I heard was someone who had a very minor car accident, had a small scratch, and a couple of weeks later, unfortunately, succumbed. So then just to move on to pertussis, which, as I showed, had the largest disease. Really, we want to protect our baby from whooping cough. Driven by Asia, largely in China, where there's a lot of macrolide resistance at the moment. We would normally give the patient azithromycin to treat it, but there is almost 100% resistance that's emerging out of the Chinese data. In neonates, the drug of choice is clarithromycin, and this is something that's going to then be monitored quite closely. We can see that over 50% of the isolates in China have now shown resistance, and that slide came from about 2-3 years ago, the data there, and now this data, which was published just this year, again, oh no, sorry, just end of last year, has shown again the resistance of circulating Bordetella pertussis strains again in Shanghai, China. And given I see the hand is raised, I'll take the question now. Given the mobility around the world, and we certainly saw that with COVID, we can expect that we're going to be getting this sort of transplant of these resistant strains across to South Africa. I saw that there was a question. Someone had their hand up. No. Okay, so then in China, the drug of choice is now Bactrim. So at least it's still a reasonably easily accessible drug, but it's then something to be aware of. What really caught my eye and is diphtheria. And for me, diphtheria has always sort of hitched a ride with the tetanus and the pertussis in terms of vaccination, and especially in women. And even today, I received an alert from the NICD on the number of diphtheria cases that have arisen in the Western Cape. So maybe not a bad thing to be in Joburg. So this article was published in 2015, and it was talking about the lessons from the outbreak. And really it is very similar. And this outbreak, again, Western Cape and KZN. And these are the things that they learned. Firstly, the power outages landed up with an unreliable vaccine cold chain, and that obviously is going to affect your entire vaccine. So really important that wherever we're taking our vaccines through, if they require a cold chain to be in place, that it is maintained. It made the comment that there was limited capacity for vaccine surveillance. And are we getting good data to say that we are managing to get to all our babies? I know that with COVID, we had a dip in the vaccination coverage, and we generally sit and it drops slowly from the baby's first vaccine. It's sort of 6 weeks and on from around just over 80%, and it drops under 80%. And so the time also for educating our moms is during the antenatal period, because they're not seeing their pediatrician or the nurse at that point necessarily, depending on what kind of practice you're working in. And so that education about the importance of childhood vaccination has to start during the pregnancy period. We have got a less than 90% vaccine coverage, and as I say, it's sort of certainly around about 80% for the actual babies. We need to now still get the coverage rates with Tdap in South Africa. We've got immigrant and refugee populations, which introduce unvaccinated individuals, and then poor school or clinic attendance also means they miss out on the routine and the catch-up immunizations. I must admit, when I've asked patients, have you got your child's Road to Health card? Often that card is elsewhere. It's at, back home somewhere else, and it worries me that the babies then are missing out on their vaccinations. There's poor maternal education and a lack of access to healthcare. Financial difficulties and location promotes non-compliance. So it's not necessarily that the mother doesn't want to, but if she hasn't got a lot of money, transport issues, and then going in for a whole day where you're going to miss work to take someone for a vaccination, those sorts of barriers are a problem. At the time, the stock of the diphtheria antitoxin was not being maintained, and in 2015, they had to get an urgent application to treat those patients who were sick with diphtheria, and then the booster vaccines were not being routinely offered to adults. So I suppose this is also going to be interesting to see with this.
Sorry, Amy, we lost you there. Hello? Amy, we lost you there. Chris, do you have any help for us?
Unfortunately, it's a connectivity issue.
I can hear you.
Oh, okay. So we lost you for the last slide, Amy.
This slide.
Yeah.
Okay, sorry. So yes, I just was saying that the issue being poor maternal education, your
Amy, we seem
So
to have
from
lost you
one-
one. There we go. We got you back.
sorry,
Yeah.
apologies. I'm going to blame the storm.
Oh, is there a storm on there? Load shedding.
But all of the above, all of the above.
Both of the above. Okay.
Sorry, so I also was just commenting that from 2015, one of the comments was that the stock of diphtheria antitoxin was not maintained, and that they had to get it especially brought in for the patients who were affected at the time. The other issue is this vaccinating adults every 10 years. Alert to say there have been another 3 cases in the Western Cape, as well as 6 asymptomatic cases. So there is a huge surge of diphtheria. All of those cases have been contact traced and the appropriate sort of measures taken from a public health point of view. But I certainly would strongly advise your patients at the moment who are with you, especially down in the Western Cape, and to a certain extent, well, it was previously in KwaZulu, but definitely in the Western Cape, you need to get your patients vaccinated, because diphtheria is a particularly nasty illness caused by toxigenic C. diphtheria. We've had 26 lab confirmed cases since 2024, which is what my slide showed there. 6 deaths, 1 in Gauteng, 5 in the Western Cape. Today's alert from NICD didn't say whether or not any of those people had died. And obviously, because, you know, people are aware of it at the moment, hopefully they're getting the medication quickly. So the clinical presentation for the grade fever and adherent membrane damage. So the management is azithromycin or penicillin. Sorry, not treat, goodness me. Prevent transmission. The diphtheria, we're amongst gynaes, it's okay. Diphtheria, antitoxin neutralizes unbound toxin, and then contact tracing and chemoprophylaxis should be started prior to the lab confirmation, and please get that diphtheria antitoxin urgently. And airway management, I've put there the NICD doctor on call number, so if you have any concern, that's who you should be calling, and start the azithromycin quickly. It is a notifiable medical condition, and so everyone should have the NMC app on their phone, and there is all the places that you can download it from. It is a Category 1 notifiable condition within 24 hours, and given the high case fatality ratio, it's important that the contact tracing is done quickly. So finally on to influenza and this little spiky blue guy. So the vaccine policies are definitely more mature, as it were, with influenza, and you can see, thankfully, we do have an influenza policy which has been put out by the NICD and the Department of Health for a number of years. And I did actually hear, on sort of a global scale, every year CDC, World Health Organization, and various big organizations get together to discuss what vaccine strains are going to be going into the southern or northern hemisphere vaccines. And with the recent political events in the US, there was a concern whether or not CDC were going to join the World Health Organization, because clearly it's really important for this meeting, and apparently the CDC thankfully are going to be, because I think to lose that massive amount of information would be a problem. So global politics certainly having an effect on health. So proportion of specimens testing positive for influenza. So this is the activity that was shown now as of February. So you can see we're pretty low at the moment, because it's not our flu season. Really, it's sitting up in the northern hemisphere at the moment, and should be dying down. From last year's flu season, our vaccine coverage was incredibly low, 5.5%. Vaccine effectiveness, though, so if you did go and take a jab, your effectiveness was about 74%. The onset was about the 3rd week of April, and went on from about the 16th week of the year to the 25th week of the year. So we should be getting, hopefully, our vaccines coming through soon, and I would strongly recommend to your patients to be getting their flu jab. So
Sorry, Amy, when did you say? I thought it was only coming through in April. Is it coming through sooner than that?
Well, it should be
Influenza
coming reasonably
vaccination.
soon, because we expect the flu season to be starting sometime in April. But like I said, I
Yeah.
couldn't find an exact date of when they're going to be releasing it. I'm not sure if Lawrence has a date yet, if you've been given one.
Is it April, Lawrence?
So it does depend. There's a number of variables, and some of it is dependent on SAHPRA as well, for their approval of the variation submission for the new strains, and then release of the stock that's received, and then retesting actually needs to be done as well. So it's a bit of a race to the start of the flu season at this time period, but we're hoping for by end of March, start of April to have stock. But remember, there's also different flu vaccines available. Sanofi's flu vaccine is not what is available on tender, so I cannot speak for the other brands available in.
Yeah, so it's the end of March, we must go and get our shots. I certainly go and get my shot. Don't know anybody else.
Yeah, so it's ideal to get it before the flu season, but remember, it's also never too late to get it. There's different strains of flu circulating, so at some point getting it through the flu season to also prevent reinfection. Yeah, it's important to get it if you have the opportunity to get the flu vaccine.
Thank you. Amy?
Great, yeah. So thank you. So That was that. So the burden of disease, so about 3.5 million cases of severe illness every year, with anywhere between sort of 290 and 650,000 deaths globally. Within South Africa, 14% of our inpatients who have a lower respiratory tract infection or a flu-like illness do actually have flu. So this is determined through our surveillance programs. The severe non-fatal illness sits at about 1,500 per 100,000 individuals, with deaths at 80 per 100,000 individuals under the age of 1. So in the bad flu season that we had not so long ago, 646 to 1,428 seasonal influenza-associated deaths in women of childbearing age occurred, so a relative risk of 2.8. So as I said, any time during pregnancy, because really our focus here is on the mom, and that's pregnant versus non-pregnant women. So our focus is on the mum, so please get it. And those patients who are particularly ill, 90% of them were HIV positive. So this is from Stats SA, and it looks at the mortality and causes of death in South Africa from 2017 to 2019. So obviously missing out COVID. And at that point there, you can see the influenza and pneumonia made up for 3.8% of all the deaths. So at the top of your natural deaths, there is diabetes, then TB, your CVA, HIV, hypertensive diseases, and then in comes influenza and pneumonia. So it really is an important cause of death in South Africa. 17,000 people dying in 2019. Birth outcomes.
Sorry, that 17,000 people dying, is that a global figure? Pregnant,
South Africa.
Non-pregnant, men, women?
South Africa, all deaths in South Africa, 17,000 in 2019. So this is from the Stats SA data, which they getting from the ICD-10 codes and things, and death notification. Wow. Yeah, so it is a massive number. Obviously, it's influenza and pneumonia, so there are going to be other forms of other viruses and bacteria and stuff in that mix, but they do specifically say influenza and pneumonia within their report.
Yeah.
So this data is from Australia. So it was just looking at the birth outcomes after pertussis and influenza diagnosed in pregnancy, and it was an article from this year from the BJOG. It was a huge population cohort, so they're looking at 1.5 million singleton births. They found pertussis in 925, of which 5.3% then were hospitalized. Influenza, though, a third of those women who developed influenza had to be hospitalized. More pertussis and influenza, the women were more likely young, they'd had a previous birth, and they'd been born overseas. Specifically for influenza, so their minority populations, patients with hypertension and diabetes were more likely to suffer from influenza. And the effect that it had on the babies, that there was an increased risk of preterm birth, low birth weight, and low 5-minute APGAR scores. The babies, the mums who had influenza, that the babies then were SGA. And if those infections were 2 weeks prior to birth, again, that risk of preterm birth and the 5-minute APGAR scores were affected and were lower. So this actually has disappeared off the World Health Organization. I was wondering if it is another one of the issues that we're having politically, but the FluNet summary shows us when the spikes are, and this is shows the July 2023 spike, and it closed off just before the winter spike that we had again in South Africa. So just to reiterate, as soon as that flu vaccine arrives towards the end of March, hopefully in early April, that everyone should be giving it and taking it themselves. The vaccine effectiveness across the 19,000, the study which this is from the published in the CID, respiratory illnesses in pregnant women across sites and seasons, 13% of PCR confirmed influenza positive pregnant women were vaccinated, compared with 22% of influenza negative pregnant women. So 16% of women were vaccinated against influenza prior to their hospitalization. So 2010 and 2016 influenza vaccines offered moderate protection against laboratory confirmed influenza. And as I pointed out from the South African 2024 data, the vaccine effectiveness sits at 74%. So just a small bit on vaccine access, the awareness and acceptability of vaccines. It's really important that we make sure that there's safety, trust, and the concern regarding effectiveness and need for information from our patients. There's often a low awareness that there's a belief that vaccination is unnecessary due to the perceptions of a low risk of infection, illness, and death. Fortunately, most people have never seen a maternal death, but it is a reality, and it's important that patients understand their risks. Patients do have high
Amy,
information needs,
can
and
I
our
just
needs
ask?
are best met by
Amy?
familiar healthcare professionals,
Hello?
and that be the gynaes. Yes.
Sorry, can I just ask that second bullet there? Why is that so? Why is there low awareness and belief that vaccination is unnecessary? There must be a reason for that disbelief. Do you know?
And that you're going to all your right appointments. Patients don't always see that they are at risk. The same as I suppose many of us don't go and get a vaccination. I'm not quite sure always why it is, but you just feel that somehow you're magically protected. There's also this sort of belief. Unfortunately, I see it from my side in the state sector when someone will say to me, but I went to a private doctor, and they feel that somehow magically, because they went and they spent money for something, that this was going to, naturally just, make everything better. Patients have lots of funny perceptions and ideas, and I know that there's actually a huge amount of research going on to exactly why is there this low awareness and belief in everything at the moment. Because of the rollout of all these new vaccines, certainly the public health sort of side of it is trying to investigate how do we get around all of these sorts of ideas, and certainly one of them is having these sorts of webinars and discussions that when you now go back into your own sort of sphere of influence, that you then impart that information and really discuss with your patients. I know we also all have limited time within practices, and so then it's sort of behoven upon you to make sure that the information is available for your patients, that it's out there in the form of pamphlets, posters if you want, and then really the use of social media, but like good social media, not the dodgy stuff. I think that's a place where we can really, direct our patients to appropriate sources of information so that they can make an informed choice. So, as I said, then the needs really are best met by familiar healthcare professionals. So, patients have a very special bond with their gynaes and with the patients, people who are looking after them during their pregnancies. And so that the onus is upon us to, advocate for our patients and educate them. We need to address their concerns, communicate the risks while taking into account the factors regarding health, individualism, and gender roles. So misconceptions that the vaccines cause disease, illness, death, or other negative outcomes, these sorts of things need to be dispelled. The fear of needles, we need to work around that with our patients. If there's no provider recommendation, this is also a barrier to receiving vaccinations. If you don't actively say it, many patients may go and do it, but they actually just need someone to say, here's a script, please go and get your vaccination. So receipt of a healthcare provider's recommendation is the factor most frequently reported as a reason for vaccination among pregnant women. And then, as I said, address their concerns. Sorry, that duplicated. So what do providers say? They say that they have a lack of knowledge or education. They consider the vaccination outside of their remit, not enough time, concerns about vaccine safety and efficacy, perceived, again, low risk of disease. If you're sitting in a practice and you've only seen, a certain couple of hundred patients, obviously you're probably not going to see that many individual cases, but that is why you need to have a look at a broader view at the number of circulating cases that are happening. So perceived lack of clinical trial data, and that certainly was an issue during the time of COVID, that it was a very new vaccine and people were concerned. And then administrative difficulties around getting staff, obtaining the vaccine, financial concerns. And I know this is something that we've been discussing, especially from the private sector. In my clinic, it's easy. I send the patient down a passage and she goes and gets a jab. Whereas within a private sector, you've got to make sure that your local pharmacy is on board, that they are willing to give and administer the vaccine. And so within your area, you need to know how do you get your patient to get their vaccine. So everyone must have their pom-poms out and be ready to advocate for vaccination. So again, are we barriers? So of patients, they said 22% reported discussing the flu vaccine with their doctor during pregnancy, but only 8% landed up being vaccinated out of one study. And more physicians said that they had discussed vaccination with their patients than patients said it was discussed. So there's that perception where maybe you feel you've discussed it, maybe you mentioned it in passing and thought that that was enough, but the patient felt that they needed more specific information. Physicians are also more likely to vaccinate if they're aware of things like CDC guidelines, if the vaccinations are given in their office, or they've received the flu vaccine themselves. So gaps in both groups' understanding of benefits of influenza vaccination for both pregnant women and newborns is one of the barriers that we need to overcome. So strategies, one-to-one information education during antenatal appointments, posters, information leaflets, and again, I say social media. The information must be address safety and efficacy and when to offer and receive the vaccination. The distribution of information within antenatal care facilities, education sessions for your you can at least point the patient to wherever the relevant pamphlets are and direct her attention. So reminder alerts to prompt conversations about vaccinations, and midwives providing vaccination is also important. Within practices, as you set practices up, you should have a schedule of how you're going to run your antenatal period and postpartum period so that all these important things are then addressed at certain times. So, but like at the beginning, there was that poll, but this is actually feedback from the last time we had a discussion, and there was about what are the barriers you experience in your current practice to apply the information presented. So one of the things, lack of evidence-based guidelines, 12% of people said. Lack of applicability of the guidelines to current practice, so 18%. I would like to argue that generally, although some people are more specialized, I certainly spend my time in maternal and fetal medicine, but this does not absolve me from talking to my patients about getting a pap smear and preventing cancer. So all of us talk to people, and all of us then must talk about vaccination because it is one of those basic things. A lack of time in terms of giving and discussing it. So then you need to think about how am I going to work around that? How am I going to make sure the information is available for my patients? Organizational and institutional. So who gives it? Where do they give it? How do they get it? 18% of the respondents last time felt that that was a barrier. Insurance and certainly within the medical aids, the vaccine within the private sector, please refer them into state so that we can assist. Patients' adherence and compliance. This is obviously always, you can take a horse to water, but you can't make it drink. So you can give out the script, you can tell them where to go, you can give them all the information, but what do they actually arrive at the nurse to get it? That is sometimes a problem. And then treatment-related adverse events, 6% of people were concerned about. So I thought that was quite interesting feedback from the last session. And that really then just brings me to say thank you very much. These are the VIPs. Our patients are all important and our focus should be there at all times. And then as also a little punt for FIGO at the end of this year, so 5th to the 9th of October, I hope to see everyone in Cape Town. I certainly intend being there and learning a lot more about women's health. And I know that there's going to be a vaccination and pregnancy session, which I'm sure is going to be very, very interesting. So thank you, everyone, for your attention and for all the questions.
Amy, thank you very much indeed on behalf of all of us. I'm going to ask Steve to thank you. Steve, if you wouldn't mind saying a few.
Thanks very much, Amy. It's wonderful to just be reminded all the time. And, I think a lot of people in private practice do forget about this. And it seems that it's really the healthcare practitioner that should be driving the process. It's quite unrelated, but there is a vaccine for UTIs, for recurrent UTIs. And I spend a lot of time talking to patients about that. And I have indeed experienced this sort of COVID-related backlash against vaccines in general, with a lot of suspicion around vaccines, and a lot of patients also suffering with recurrent UTIs and would clearly benefit from it, but really not keen, just simply because there's this whole overwhelming suspicion around the the vaccine as such. So I don't know if you've got any ideas around that or any tricks to explain, to really get patients to remove that whole suspicion around vaccines. I know we have spoken a little bit about that, but what are your thoughts on that?
Sorry, I lost you for the last part. I can hear thunder above
okay.
me. Apologies. Just
Okay,
I
no,
heard
let
you
me-
about, you're talking about COVID, like the hesitation about
Yeah.
the uptake of the vaccination.
Yeah, no, I just spent a lot of time speaking to patients about recurrent urinary tract infections, and there is now a vaccine for
Yeah.
urinary tract infections. But I'm finding even though patients are quite struggling a lot with the problem, they are still remain reluctant to go for a vaccine. And indeed, this vaccine is inhaled vaccine; it's not even injectable. But what are your thoughts around just really getting patients to overcome this suspicion that has emerged, around the whole COVID vaccine, theories and suspicion?
I think one of the things is not to dismiss people's concerns and the fact that you can get like a Guillain-Barré or whatever after a vaccine, but I think is to try and put it in perspective. And I seem to remember, actually, I think it was Trudy Smith in one of her talks where it was really talking about the risk of embolism to do with one of the contraceptives, and she sort of gave the numbers. I can't remember the numbers now, but your sort of risk of an embolism from, say, the pill was like, say, 1 in 10,000, but your risk of an embolism when you're pregnant was sort of 1 in 1,000, something like that. So I think the thing is to get those sorts of things and get them across to people to try and put it in perspective. What are the risks? I think minimizing and saying that there is no risk will just make the patient feel that you're not trustworthy, that you're not, and I think sometimes you have to sit and listen to the story about their auntie's mother who did whatever and therefore such and such happened, and then to try and pick out and tease what was the actual issue, and then if necessary, because we don't all have the answers all the time, is to rather say to the patient, can you come back, or can I send you?
You are breaking up, Amy. Or you have broken up, Amy.
It's the thunderstorm. There's a huge thunderstorm
They're not
there.
having to pay, but if you do have a nurse practitioner or someone who can work with you, then maybe that's the place to sort of use someone like that.
Okay. No, that's excellent. No, great. I mean, they're changing the face of our day-to-day practice. I think vaccines and certainly taking making a big impact. And but thanks very much for the time taken to prepare this talk and to actually give the talk. We really did appreciate it, and we do look forward to seeing you in Cape Town at FIGO. Things are definitely getting much more organized, and Pete's, I'm sure, very busy organizing the whole conference. And again, thanks to the sponsors. And Pete, what is happening next week?
I think we're
yet?
just going to put up the poll again.
Of course, yeah.
Can we just have a look at the prayer list? What's it called again? Not the prayer list. The belief ladder. That's right. Yes. We'd like to see how you've changed your attitudes, ladies and gentlemen.
I hope I answered all the questions.
You certainly have, Amy. We'll give the correspondents a few minutes just to enter in their answers, and then we can compare. While they're doing that, I'd just like to ask Darren, I'd love it if the Sanofi reps can come and drop off some information. Maybe not the posters. Posters are expensive. But small little cards or pamphlets. Patients love going out with a pamphlet, and it saves time for us and also gives them something to consider. And if they've got one of those little scanning things, a QR scanner, so it gives them more information. And I know that you're not allowed to mention necessarily your particular product, but it's still very, very useful to have a Sanofi handout with the reasons for vaccination in pregnancy. And people still walk around, as we've seen, with this high probability of the danger of vaccination in pregnancy, which is a fallacy. So it would be wonderful if you could get your team out there, Lawrence, to drop off some information on the subject.
Of course, thanks for that, Peter, and you're touching on a very important point, which is around the education, not only for our HCPs and OBGYNs, but for patients as well, right? So we do have information available in like infographic format. So for us as HCPs, that really explains the efficacy and the safety component of these vaccines and considerations that you need to take into account. But then importantly, also we have material that is what we call patient focused, which just helps you as an OBGYN to discuss with your pregnant patient what the disease is, why it's important to consider that vaccine. So we are working on a bunch of initiatives to roll out this treatment. So you'll definitely get a visit from some of our medical team members throughout this year. And then, as Amy was alluding to, Sanofi will also have a definite presence at FIGO at the end of this year. So even our global team is going to be involved, and we will be having both a medical booth and a symposium. And the way we approach this usually is we do 4 different segments within the symposium. So dedicated then to flu, pertussis, COVID actually still as well, because it's also one of the vaccines we recommend in pregnancy. And then from an RSV perspective, really importantly, talking about shared decision making. So really that touches on discussing with your patient what are the options. So different to the other diseases where you have really that window of vulnerability, as Amy was showing, where you want to cover that with vaccination and pregnancy. With RSV, it becomes a little bit more complicated. There are some considerations to take into account, but also you will have then the infant protection option as an alternative as well. So once we have registration and availability of this infant protection option in South Africa, then all of this information will be captured within this shared approach from our FIGO symposium perspective. And again, lots of information will be available. In the meantime, we'll definitely visit you guys, Peter, in Cape Town as well, and share some of the information we can share at this point.
Thank you. Amy, would you like to go through the poll and see what the changes are?
Hi, can
Amy?
you hear me?
Yep.
The poll was designed, I think, on the other side. So I don't know if they can see it better than me. I can't see the comparison. Lawrence, have you got the comparison on your side?
I don't think we can see the comparison as well, but definitely we can give PFFSA some feedback post the webinar, Peter. Then we can also just have a look. If we spot that there's a gap in a specific area, then we can also focus our educational initiatives on that, and we'll liaise closely with you guys on that.
Thank you. Lawrence, there's just so much in a 15-minute consultation that you can discuss. And I mean, there's important things and less important things. And this is one of the most important things. So if we could speed up our discussion by means of patient information, brochures, and literature, it would be wonderful. So, Steve, the final word from you.
Oh, well, thanks again. One wonderful session. Thanks to the sponsors. I think was a great understanding how this belief poll works. So, and I'm sure we can use it as we go forward. And but thanks again, Pete. Do we have an idea of what's happening next week, or we'll let everyone know?
We'll let everybody know when that's firmed up. Yeah. And I like this business. I'm sorry I called it a prayer list or a hymn sheet. It actually is a belief poll. And I think we're going to have to look at these things in the future. So thank you, ladies and gentlemen. Safe home. Steve, all the very best for being with us this afternoon. And a final thank you to our sponsors, Sanofi, and of course, Amy Wise, for all her wise words. All the very best, safe home, and good night.
Thank you very much.
Good night. Thanks very much.
Very much, Amy.
Thanks.